Today I will present a case and will discuss can a common GI medicine, here in this case is rifaximin, rifaximin can cause significant harm. So, history of the patient. Patient is 42 years female, known case of hypothyroidism on thyroxine. Presented with fever with chills since 15 days. She had loose stools 4 to 5 episodes a day, small quantity since 15 days. She had generalized reddish non-pruritic rash since 12 days. She also had oral ulcers, painful deglutition, and nausea since 8 days. She took some treatment from outside, was given oral medications, details of which were not available. Outside, only two reports were there, CBC which was normal and SGPT was raised, 247. On physical examination, patient was febrile, 102 degree Fahrenheit. Tachycardia was there, pulse was 110 per minute. BP was normal, saturation was normal. There was generalized maculopapular rash, which was non-blanching. Icteric tinge was there with the tenderness in the right upper quadrant of abdomen. RS, CVS and CNS examination was normal. So as you can see, in both upper limb, lower limb, maculopapular rash is there. And on investigation, hemoglobin platelets were normal. Leukocytosis was there, 16,400 counts. Bilirubin was raised, 5.4 total. Direct bilirubin was 4.4. SGOT, SGPT was raised, 174, 141. Alkaline phosphatase was also raised, 575. Albumin was in the lower side, 3.1. Prothrombin time and INR was raised, suggesting coagulopathy. KFT was normal, electrolytes were normal. On urine routine, there was traces of protein. ESR was normal, CRP was 46, which was raised. Ferritin was very high, it was more than 1000, and procalcitonin level was also high. Although blood culture was negative, ANA was also done to rule out connective tissue disorder, which came negative. Fever profile all were negative: dengue, malaria, scrub, lepto, chikungunya, viral markers, HIV, HBsAg, HCV, HEV IgM, HEV IgM, all were negative. Further investigations were done. X-ray was normal. USG was suggestive of mild hepatomegaly, moderate splenomegaly, and edematous gallbladder walls. Echo was normal. There were no vegetations, no clots. Upper GI scopy was done, which was suggestive of severe esophagitis and erosive pangastritis. Biopsy was taken from the esophageal mucosa, which was suggestive of severe esophagitis. So, as you can see, these are the slides of esophagus showing whitish plaques and ulcerations. This is a histopathological image. It's showing necrotic area here. Uh, I will ask Dr. Prajakta ma'am to kindly explain the histopath picture here.
Okay, so we had a esophageal biopsy, which again demonstrated, just a second, which demonstrated an ulcerated epithelial lining. There was vacuolar degeneration, changes in the adjacent epithelium, squamous epithelium, and full thickness epithelial damage. There was full thickness epithelial necrosis. You can see slightly viable tissue here. Then again, the complete necrotic material with the full thickness. So we receive a esophageal biopsy, which are mucosal biopsy. These are not full thickness biopsy. So we cannot comment whether there was a bulla formation or anything like that. But probably because of some underlying condition, this was acute esophagitis with full thickness necrosis here.
Thank you, Dr. Prajakta ma'am. So, in short summary, 42 years female, known case of hypothyroidism on thyroxine, complaints of fever, loose stools, rash, jaundice, oral ulcers, and painful deglutition for the last 15 days. Examination showed that she was febrile, ecteric, generalized maculopapular rash, right upper quadrant abdominal tenderness. On investigation, there was leukocytosis, hepatitis, splenomegaly, coagulopathy, hyperferritinemia, severe esophagitis, and pan-gastritis. So with this, we kept a differential diagnosis as viral exanthem, drug reaction, vasculitis secondary to infection, connective tissue disorder, and macrophage activation syndrome. Uh, in the history, she told that she took some medicine. So we presume probably she had taken amoxicillin. Uh, there are many cases of drug-induced rash associated with amoxicillin, and other differential diagnoses such as connective tissue disorder, ANA was negative. In macrophage activation syndrome, the typical rash was not present, and all the fever profile were negative. So, a diagnosis of drug-induced rash secondary to beta-lactam antibiotics with toxic hepatitis was made, and she was started on injection dexamethasone 4 mg 12 hourly, and antibiotic only azithromycin was kept. On day 4, there was increase in the liver enzymes, and she had altered mental status. AST raised to 1171, ALT was 488, ammonia level were high, N-acetylcysteine infusion, ursodeoxycholic acid, rifaximin were started. Uh, on After 2 days, her fever subsided, and on day 7, her AST-ALT level reduced. INR also improved from 1.7 to 1.39, although rash was persistent. So with this, she was discharged after almost 10 days of hospital stay with diagnosis of acute febrile illness with toxic hepatitis, with rash, with severe esophagitis, query drug-induced, query viral. And she was discharged on prednisolone 30 mg OD in tapering dose, ursodeoxycholic acid 300 BD, rifaximin 550 mg BD, and thyroxine as she was taking already with local ointments for rash. Now, after 7 days, she presented with a recurrence of fever which was high grade, and there was exfoliation of skin with pus discharge from oral cavities, eyes, neck, upper back. There was persistent jaundice. On examination, she was febrile, 103 degree Fahrenheit. Tachycardia was there, pulse was 128 per minute. BP was okay. She was tachypneic, RR was 26 per minute, although saturation was normal. She was icteric, pale, and there were pus discharges from the neck area, upper back, and bilateral cubital areas. So this is the picture. You can see the back of the patient, which is denuded skin with pus discharges from the neck area. On investigation, her HB is dropped 9.8, although counts are normal. AST/LDR persistently raised 223, 466. Bilirubin was 10 total. INR was deranged 1.5. Alkaline phosphate is still raised 526. KFT was normal. This time CRP increased to 95. PCT was 5. With this picture, I would like to ask Dr. Pooja ma'am to take over and explain the differentials.
So as Dr. Bala mentioned that the patient had history of fever with rash and he was started on antibiotics and we suspected it was drug reaction and the patient, I will just summarize the history in short. So the 42-year-old female patient, she had history of fever with chills and rigor since 15 days, nausea and vomiting since 10 days, oral ulcers since 8 days, and joint pains since 7 days. On examination, general examination, the patient was febrile, irritable, pulse was raised, normal. I mean, BP was also normal. Systemic examination on examination were within normal limit. When we did the skin examination, there was generalized erythematous maculopapular rash was present all over the body with the islands of normal skin. The oral cavity had some erosions and well-defined ulcers, and the genitals were within normal limit. So differential diagnosis on the first point when she had a history of maculopapular rash, we kept few differential diagnoses. For the first one was dengue, chikungunya. It could be SLE or drug reaction. This is the first time when the patient had that maculopapular rash. And the final diagnosis was drug reaction because all the parameters were normal. All her dengue, malaria, type, everything were within normal limits. And we stopped the injection monosef. The patient was already on injection monosef. The injection monosef was stopped and we started her on injection Dexa, 4 mg IV 12 hourly, and supportive treatment was given for 3 days. Patient responded nicely with disappearance of erythema and healing of ulcers, and there was exfoliation of skin. That is a sign when patient responds to the treatment of drug reaction. And on the fourth day, on patient's request, discharge was given. So on discharge, the patient was given the supportive treatment, which was tablet omnacotyl, tablet rifaximin, and other supportive treatments. But within 6 days, there was rapid progression of skin peeling. Excuse me. Within 6 days, there was rapid progression of skin peeling, and after second day of discharge, the patient came on 6th day after the previous discharge. So treatment on discharge, as I mentioned, the patient was given tablet Rifagut, Omdacotyl, and levocetirizine. And when she came on the 6th day, as you can, I'll be showing you, there was sheets of exfoliation with normal skin. There was, I mean, more than 80% body surface area was involved. On oral examination, there was sloughing, exfoliation, and oral erosions. Even her genitals were involved. More than 80% of her skin was eroded. So the final diagnosis is toxic epidermal necrolysis. Now, I would like to add one point. If the patient has a drug reaction, first we suspect a patient of drug reaction, we stopped her injection monosef, which is cephalosporin. Cephalosporins are culprit for causing drug reaction. And if the patient has a drug reaction and if we give patients any other drugs which can trigger drug reactions, the patient will respond to those drug reaction very faster because the delayed because the patient is already sensitized. So the second time when she was started with tablet Rifagut, we were not aware that Rifagut can cause toxic epidermal necrolysis. We immediately stopped Rifagut. Injection dexamethasone 4 mg IV 12 hourly was started and capsule cyclosporin 100 mg was started. Injection linozolid because the patient will be susceptible to gram-positive infections. So if there's a one interesting article that rifaximin can cause toxic epidermal necrolysis because most of them believe that rifaximin is not, it doesn't have absorption through the bloodstream, but there is very less percentage, like 3 to 4% it gets absorbed in the blood. And that minuscule amount of rifaximin triggered the drug reaction and it went into toxic epidermal necrolysis, which is a acute skin condition and which can be life-threatening. Now, coming to toxic epidermal necrolysis, we have some parameters to see the prognosis of patient. There are 7 parameters when you see a patient of 10. First is the age. If the age is more than 40, there's a +1 that adds risk for the management of 10 patient. Then the heart rate. If the heart rate is more than 120, there is increase in risk of death. The malignancy, if there is malignancy associated, it also adds to risk. Then the body surface area. If more than 10%, then the point is 1. If the blood urea is more than 10 millimole per liter, that also adds to 1 more point. The bicarbs level, if less than 20 millimole per liter, that also adds 1 more point. And the glucose, if more than 14 millimole per liter. So there are 7 parameters. And in this patient, she was more than 40. Her heart rate was more than 120. She had no malignancy. Her body surface area was more than, I told you it was more than 80 to 90%. So there are already 3 points. The blood urea was also raised and the bicarbs were low on the 3rd day of her admission and her glucose were deranged. So the prognosis, if you count, if there is a score of 1, then the prognosis is 3.2%. If the score is 2, the prognosis of is 12.1%, 3 35.8%, 4 was 58.3, and 5 is more than 90%. Our patient had score of 5, which increased the chances of uh, death. Now, coming to which drugs can cause 10. The most notorious of the group are cephalosporins, sulfonamides, NSAIDs, anticonvulsants. The most commonly used, rampantly used is phenytoin, anti-TB drug, INH and rifampicin, antiviral drugs, nevirapine. These are the few drugs which I have mentioned, and that's it.
Thank you. House is open for discussion.
Sir,
I just say it's a little complicated case, I see not one reaction here to probably drug hypersensitivity syndrome and toxic epidermolysis necrolysis together. But the first impression is the last impression. Dr. Debashis, what was your impression when you first saw the patient maculopapular rash, liver enzymes elevated? Because the esophageal findings which was narrated was not very typical of a drug reaction. So was any loose tablets given or some alternative medications were given?
sir,
And how did you suspect drug reaction at that point of time?
because uh, so extensive rash was there.
Yes.
S- The patient had extensive rash. Initially, we thought whether it is a viral exanthem or whether she presented with a connective tissue disorder. So at no stage we were very sure what exactly a diagnosis be made. Yes,
If we look at the first parameters when she was started on injection monosef, so her CBC, her eosinophils were raised, and her LFTs, the alkaline phosphatase, and SGOT, SGPOT were more than 3 to 4 times it was elevated. So that was one of the clue, and other parameters which suggest fever with maculopapular rash. Most of the infections were negative. And when we stopped injection monosef and when we started steroids, even the blood culture was also done and then the steroids were started. The patient, she responded very nicely. Her rash was resolved and that was a suspect that it is a drug reaction.
Okay. Because I look at it as a single disease, just as a continuation of what started from the beginning. So probably this could be a case of DRESS, what we call it as drug reaction,
Stress,
eosinophilia, and systemic
systemic
symptoms.
involvement. Yes, sir.
Because this patient has a systemic involvement, a very strong hepatitis component.
Yes, sir.
And rifaximin just can be coincidental, in my
So that
opinion.
that is
Yeah, that's my impression.
yes.
Because although any drug can cause any reaction
So
for
it's a
that matter.
very rare drug, and if the patient already has a drug reaction, the hypersensitivity reaction is already going on. And if
Yes,
we
yes,
challenge with another drug which is causing a drug reaction, the reaction exacerbates, and the the appearance of reaction or the complications appear faster. So this is a take-home message that whenever we see a patient of drug reaction, we have to be very careful while prescribing drugs. So I think the take-home message for all of us is when we see a patient of drug reaction, we should mention on the front page, or we should educate the patient that you have a drug reaction. Even a painkiller can trigger a drug reaction.
and what was the status of the mucosa? Because I didn't see a clear picture.
So
Was
the
it very typical of
yes,
SJS?
yes, yes, it was. Even the
Okay.
genitals were also
Yeah,
involved, sir.
sir wants to comment. Okay, was sir, you want to comment?
Yeah, actually, in fact, the unfortunately we lost this patient after a period of 5 to 6 days. She was so sick. The then whenever such deaths occur, which we don't expect them to occur, we have discussed them in our death audit. And when it was discussed in our death audit, we felt that why the second rash was there, which was more severe. So the explanation probably is hypersensitization in an individual because of previous drug which has been taken is one explanation. And as you rightly said, the some alternative medicine which she has taken could be responsible for the first rash, and but in spite of steroids she has developed toxic epidermal necrosis when the only drug was rifaximin. Now to confirm that the drug is responsible for this particular event, you have to have four things. One, the onset after the drug, stopping of drug leading to reduction, re-challenge, and which
Challenge.
is in clinical practice you can't do it. But when Pooja told me, I said first thing that rifaximin is not absorbed. So how come it would lead to toxic epidermal necrosis? So I was not believing. But then we got the literature which said that there are case reports of 10
Yes.
after rifaximin. So there is a possibility, and one has to be very cautious using these drugs because we, in fact, every day we send about 8 to 10 prescription of rifaximin to our patients. So the idea was that one would alarm people, though the incidents and the case reports are very rare, but we thought that we should share this experience. In
Yes.
fact, in the death audit which we had internally also, we had an intense discussion that why she died because of some macrophage activation syndrome and all other things were also discussed.
Yes,
Thank you.
before getting late, I just have few couple of messages from this discussion because we don't have any diagnostic tests to prove whether it's a drug reaction. So everything boils to your clinical judgment and thorough history taking. I was fortunate to be a part of the IDBL National Guideline Task Force for formulating guidelines for the management of SJS. Whenever in doubt, don't give dexamethasone because it's a long-acting drug. It takes time to act. If you want a quick relief, better give solometrol or methylprednisolone. And cyclosporin is a very, very life-saving drug that has dramatically changed the treatment outcome in patients of SJS and 10. Don't hesitate to give it in spite of having a renal failure as well. You can give an adjusted dose. So that's the very important thing. You can save a life by giving cyclosporin to this patient. So thank you, Pooja, for the
Thank you, sir.
excellent presentation.
Patient was chronic alcoholic. Chronic deficiency can lead to low hemoglobin, neutrophilic leukocytosis, but the eosinophils were normal. The LFTs, in spite of being alcoholic, chronic alcoholic, SGOT and SGPT were mildly raised. The alkaline phosphatase was also mildly raised. ESR was raised. RA factor was also significantly raised. VTRL in dilution was negative. ANA was also negative. Lipase was significantly increased, which was 2197. The normal range is 23 to 30 units per liter. The pus, when I tried to do the biopsy, there was exudation of pus. So we did the pus gram stain, it was negative. The blood culture was negative. And we did the skin biopsy also, which was suggestive of lobular panniculitis. And CT abdomen, which showed acute on chronic pancreatitis with mild ascites. Uh, when we try to, histopathology, I'll ask Prajakta to take over and explain the histopathology of the patient. Over to you, Prajakta.
So, with those clinical differentials on mind, we received a skin biopsy from the lower limb lesion, one of the lower limb lesions, which showed, just a second, which demonstrated, actually, I've not included the epithelium in this, but the epithelium was normal. Uh, in contrast to the clinical differentials of Fried's syndrome and pyoderma gangrenosum, the papillary dermis and the dermis was also normal. There was no vasculitis, and we can see deep down there in the subcutaneous tissue, this is all your adipose tissue, the subcutaneous tissue is showing dense inflammatory infiltrate. So to see the nature of the infiltrate, we go on to the high power view, which is showing chronic inflammation, which is predominantly composed of all these foamy histiocytes, which have even engulfed some necrotic debris material. This yellowish is the necrotic debris material. These vacuolated spaces are your fat spaces, adipose tissue. So there is dense lobular panniculitis, subcutaneous panniculitis. On further higher views, there was this histiocytic collection with giant cells. You can see one giant cell here. Inflicted response to the phagocytic system. So over to you, ma'am.
So, based on the histopathology and the history, which was acute fever with nodules, tender nodules, and pain in abdomen, the histopathology, which is suggestive of lobular panniculitis, and the patient had history of chronic alcoholism, pain in abdomen, and polyarthritis. The diagnosis is pancreatic panniculitis. This is a very rare condition. Only two cases have been reported. This is a case report from Malaysia. If you see, the patient had a similar complaint. This is a history of 70-year-old male patient. He had the same history of acute abdominal pain with nodules and chronic alcoholic history and similar lesions. You can see the erythematous tender nodules, which is brown, present only on the extremities, and the patient had also the history of oligoarthritis. So, coming to the discussion part, pancreatic panniculitis is a very rare condition with the incidence of 0.3 to 3% among patients with pancreatic disease. It may arise with congenital causes of pancreatic abnormalities and in those with secondary causes of pancreatitis, such as acute or chronic, secondary to chronic alcoholic consumption, cholelithiasis, trauma, and viral infections, or rarely pancreatic carcinomas and pseudocysts. Rarer causes includes pancreatitis following liver transplantation, renal or combined renal and pancreatic transplantation, systemic lupus erythematosus, and retroviral disease with hemophagocytic syndrome. The pathophysiology of pancreatic panniculitis is likely due to massive release of pancreatic enzyme such as lipase, amylase, and trypsin into the systemic blood circulation, leading to increased vascular permeability resulting in fatty acid release from adipocytes, causing fat necrosis. So the take-home message, one nodule can have multiple diagnoses, and a proper clinical examination and doing all the investigation. The skin biopsy was the main helpful. It helped in our diagnosis because we were thinking about sweet syndrome. But if you see the sweet syndrome and pancreatic panniculitis, the difference is in the histopathology, because in both there is leukocytosis, neutrophilic infiltrate is present. But in histopath sweet syndrome, the there is neutrophils are present in reticular dermis. There is neutrophilic accumulation. Whereas in pancreatic panniculitis, it is a lobular panniculitis and there is a histiocyte aggregation. So this was a very important and a very different case of pancreatic panniculitis. Thank you very much. Any questions?
Any questions from the audience? Because this is a very really interesting case. Yeah.
So the treatment was done by the GI. He was started on, as a dermat, we had started him on injection dexamethasone, and even the goutnil, tablet goutnil was given, and then octreotide injections were given by gastroenterologist. And the patient's nodules have been resolved now completely.
Pooja, uh, the prevalence of panniculitis, is it more with alcoholic pancreatitis? Is it
Very
described?
rare, very rare.
It's rare, but
So,
amongst the causes of pancreatitis,
mhm.
is it more with alcohol-induced
Yes,
pancreatitis?
sir.
Because see, there's no explanation why it is more with alcoholic pancreatitis, but whatever case reports are there, they are with alcoholic pancreatitis. In fact, we see pancreatitis in and out, day in and day out. Almost at one particular time, 8 or 10 patients are admitted with pancreatitis. But I would say that in 42 years of my career, this probably could be the second case of panniculitis secondary to pancreatitis. So it's not a very common condition. That's why we thought that we should present this. Secondly, there is a new concept of fat coming in pancreas. I mean, the importance of fat in the pancreas. So whenever you have an episode of pancreatitis and you have more fat in pancreatitis, that is associated more with fatty degeneration, necrosis, and necrotizing pancreatitis. Like you have a fat in the liver, you have fat in the pancreas, you have more. These patients, I think his lipase levels were sky high.
Yes.
What were the lipase levels?
2132.
Almost 10 times higher.
10 times higher.
No,
It is
actually, in fact,
So is it
it was
29.
29,000. Actually,
okay.
yeah, I still remember it was 29,000. Yeah.
Okay.
So that was there. It was not 2,000, 29,000. So whenever you have a increased lipase levels, probably that leads to more of lipolysis, which can be in the pancreas, in the skin, anywhere in the, as the surgeons operate many of these patients, they would see all fat necrosis. So, I mean, these phenomena is fat necrosis, and which can also involve the joints and cause
So that's why the RA factor was positive. It's a
yeah.
pseudo
Sir, do you
oligoarthritis.
see more lipase in alcoholic pancreatitis as compared to non-alcoholic?
Not really, because the alcoholic pancreatitis is associated sometimes with chronic pancreatitis. And chronic on acute pancreatitis, the enzyme elevation may not be so much. So I don't think, depending on etiology, you can say that this pancreatitis is associated with more lipase elevation. But alcoholic, because there is an element of chronic pancreatitis, you may not have that much enzyme elevation. But ultimately, lipase would depend upon the fat.
Okay.
secretion of lipase leading to fat necrosis is the pathogenesis of this.
Yeah, I think these cases like this requires a very high index of suspicion because it's a very rare cases. Just question to Dr. Prajakta, is it more of a neutrophilic lobular panniculitis to begin with? Where do you say the ghost cells and later it gets converted into histiocytic panniculitis? Yeah.
It's a chronic condition to begin with. Probably it would start with a neutrophilic infiltrate. It is basically the enzymatic degradation of the fat. So necrosis is always, necrosis will be always surrounded by your acute inflammatory infiltrate, and later on it will be overtaken by your chronic inflammatory cells.
Yes.
So to digest those debris, you need your phagocytic system, your defense mechanism. It takes over.
Plus you require ghost cells also, and
Yes.
sometimes foci calcification can also result.
Correct, correct.
So the message here is actually the role of histopathology. Puja, that is the most important thing. You require high index of suspicion, and histopathology is very, very easy technique in dermatology. Unless if you do like a pancreatic biopsy or liver biopsy, which may be little complicated, taking a skin biopsy is always very easy. So I would recommend all of you to take a skin biopsy. That's a very easy way of diagnosing a dermatological disease. So thank you, Puja, for the excellent presentation. Thank you.
Thank you very much.
Question is that what was the treatment and how was the response? That just I want to know that.
See, treatment consists of treatment of pancreatitis only. There is no specific different treatment for it. It's a result of pancreatitis. So stopping of alcohol, whatever conventional treatment of pancreatitis has to be given.
Very stormy pancreatitis. I had to drain the collections in third week. One of the clicking point of this patient was what are the case what you reported? All has been reported in the severe form. We'll never get a panniculitis in the milder form of an acute pancreatitis. It is always a severe form of pancreatitis. It was we were very running in the second week. He's throwing 102, 103 fever. We are differential of cellulitis versus what we are fitting into it. Finally, come to know after doing Dopplers and a lot of things. It is something related to some vasculitis where we need to involve a dermatologist. And simultaneously, we have to treat his severe form of pancreatitis. We have to drain in third to third. I think, and remember, we had to drain this in the third week. Or it's not like a completely matured form of the collection, but considering the sepsis and very stormy pancreatitis, the patient resolved very nicely after drainage, antibiotics with some symptomatic treatment from dermatologist. So that was a takeaway. High 29,000 amylase lipase, stormy pancreatitis, alcohol. Then we can really make sure that this can be a form of panniculitis, as it is a very rare phenomenon. Yes.
I think Dr. Sandeep Pal from online wants to say something. How to connect him to?
Yeah, can you hear me? Can you hear me?
Dr. Pal, you are on.
Yeah, so just a comment because this patient, this panniculitis usually occurs in pancreatitis, and because in this patient the lipase level was so high, so I think chronic pancreatitis may not be there. It was an acute pancreatitis, and at the same time, this condition is also very common in malignancy, underlying pancreatic malignancy. So we should very meticulously rule out pancreatic malignancy also. And the other thing in the treatment for the condition per se, like for the panniculitis, analgesics and all are there. But if it is like very much inflamed, some compression bandage might help. So that is another treatment which can be helpful in this panniculitis.
Yeah, this patient had acute pancreatitis only. We presented this as severe acute pancreatitis. He had fluid collection. He had a stormy course and fever. In fact, the clinical, because we wanted to emphasize more on the dermat aspects of it, that's why we didn't go into the details of the clinical history, but we tell you that it's a severe acute pancreatitis.
Good case.
Shall we move on to the next case?
I was just hoping to introduce the online chairpersons for a moment. Yeah. So thank you, Sandeep and Muni, for joining in. Sorry, So we have Sandeep Pal here. Thanks, Sandeep, for joining in. Dr. Sandeep Pal is a fantastic gastroenterologist and advanced endoscopist in NH Hospital in Kolkata. Very experienced, does fantastic live courses, and we are really honored to have him here today. And along with them, we have our international chairperson, Thiru Vengadam Muniraj. Thiru is his short form. So Thiru and I are good friends from back in days when we were interviewing together for fellowship. Thiru is the Associate Professor of Medicine at Yale University in the US, and he's the Vice Chief of Endoscopy and the Director of Advanced Endoscopy at Yale. And he's the Associate Chief of Endoscopy there, as well as the Director of Bariatric Endoscopy. So welcome, Thiru. Thank you for logging and sparing your time. Thank you.
Yeah, thank you, Saurabh, and thank you everyone for having me. It's a great honor to be a part of your conference. Thank you again.
Yes. The second case is can a common GI medicine do harm? I mean, yeah, all medicines can do harm, and you have to be really a adverse drug reaction conscious physicians. We need a more safety physicians. And presenting the first case is Dr. Debashish Bala, and he will be presenting the first case.
Thank you, sir. Good evening, everyone.
Phagocytic syndrome. The pathophysiology of pancreatic panniculitis is likely due to massive release of pancreatic enzyme such as lipase, amylase, and trypsin into the systemic blood circulation, leading to increased vascular permeability, resulting in fatty acid release from adipocytes, causing fat necrosis. So the take-home message, one nodule can have multiple diagnoses, and a proper clinical examination and doing all the investigation. The skin biopsy was the main helpful. It helped in our diagnosis because we were thinking about sweet syndrome. But if you see the sweet syndrome and pancreatic panniculitis, the difference is in the histopathology, because in both there is leukocytosis, neutrophilic infiltrate is present, but in histopath sweet syndrome, the there is neutrophils are present in reticular dermis. There is neutrophilic accumulation, whereas in pancreatic panniculitis it is a lobular panniculitis and there is a histiocyte aggregation. So this was a very important and a very different case of pancreatic panniculitis. Thank you very much. Any questions?
Any questions from the audience? Because this is a very really interesting case. Yeah.
So the treatment was done by the GI. He was started on as a dermat. We had started him on injection dexamethasone, and even the goutnil tablet goutnil was given, and then octreotide injections were given by gastroenterologist. And the patient's nodules have been resolved now completely.
Pooja, the prevalence of panniculitis, is it more with alcoholic pancreatitis? Is it
Very
described?
rare, very rare.
It's rare,
Huh.
but
So,
amongst the causes of pancreatitis,
mhm.
is it more with
Yes,
alcohol-induced
yes,
pancreatitis?
sir.
Because see, there is no explanation why it is more with alcoholic pancreatitis, but whatever case reports are there, they are with alcoholic pancreatitis. In fact, we see pancreatitis in and out, day in and day out. Almost at one particular time, 8 or 10 patients are admitted with pancreatitis. But I would say that in 42 years of my career, this probably could be the second case of panniculitis secondary to pancreatitis. So it's not a very common condition. That's why we thought that we should present this. Secondly, there is a new concept of fat coming in pancreas. I mean, the importance of fat in the pancreas. So whenever you have an episode of pancreatitis and you have more fat in pancreatitis, that is associated more with fatty degeneration, necrosis, and necrotizing pancreatitis. Like you have a fat in the liver, you have fat in the pancreas, you have more. These patients, I think his lipase levels were
Very
sky
high.
high.
Yes,
Yes.
What
yes.
were the lipase levels?
2132,
Almost 10 times higher.
10 times higher. It
No,
is up
actually, in fact,
So is it
it was
29.
29,000. Actually,
okay?
yeah, I still remember it was 29,000. Yeah.
Okay.
So that was there. It was not 2,000, 29,000. So whenever you have a
Oh, lapse.
increase lipase levels, probably that leads to more of lipolysis, which can be in the pancreas, in the skin, anywhere in the, as the surgeons operate many of these patients, they would see all fat necrosis. So, I mean, these phenomena is fat necrosis, and which can also involve the joints and cause
So
the
that's why the RA factor was positive. It's a
yeah.
pseudo
Sir, do you
oligoarthritis.
see more lipase in alcoholic pancreatitis as compared to
Uh,
non-alcoholic?
Not really, because the alcoholic pancreatitis is associated sometimes with chronic pancreatitis.
Okay.
And chronic on acute pancreatitis, the enzyme elevation may not be so much. So I don't think, depending on etiology, you can say that this pancreatitis is associated with more lipase elevation. But alcoholic, because there is an element of chronic pancreatitis, you may not have that much enzyme elevation. But ultimately, lipase would depend upon the fat
Okay.
secretion of lipase leading to fat necrosis is the pathogenesis of this.
Yeah, I think these cases like this requires a very high index of suspicion because it's a very rare cases. Just question to Dr. Prajakta, is it more of a neutrophilic lobular paniculitis to begin with? Where do you see the ghost cells and later it gets converted into histiocytic paniculitis? Yeah.
It's a chronic condition to begin with. Probably it would start with a neutrophilic infiltrate. It is basically the enzymatic degradation of the fat. So necrosis is always, necrosis will be always surrounded by your acute inflammatory infiltrate, and later on it will be overtaken by your chronic inflammatory cells.
Yes.
So to digest those debris, you need your phagocytic system, your defense mechanism.
Yeah.
It takes over.
Plus you require ghost cells also and
Yes.
sometimes foci of calcification can also result.
Correct, correct.
So the message here is actually the role of histopathology. Puja, that is the most important thing. You require high index of suspicion and histopathology is very, very easy technique in dermatology. Unless if you do like a pancreatic biopsy or liver biopsy, which may be little complicated, taking a skin biopsy is always very easy. So I would recommend all of you to take a skin biopsy. That's a very easy way of diagnosing a dermatological disease. So thank you, Puja, for the excellent
Thank you.
presentation.
Thank
Thank
you
you.
very much.
Question is that what was the treatment and how was the response? That just I want to know that.
See, treatment consists of treatment of pancreatitis only. There is no specific different treatment for it. It's a result of pancreatitis. So stopping of alcohol, whatever conventional treatment of pancreatitis has to be given.
Very stormy pancreatitis. I had to drain the collections in third week. So one of the clicking point of this patient was, what are the case what you reported? All has been reported in the severe form. We'll never get a paniculitis in the milder form of an acute pancreatitis. It is always a severe form of pancreatitis. It was we were very running in the second week. He's throwing 102, 103 fever. We are differential of cellulitis versus what she was. We are fitting into it. Finally, come to know after doing Dopplers and lot of things, it is something related to some vasculitis where we need to involve a dermatologist, and simultaneously we have to treat his severe form of pancreatitis. We have to drain in third to third, I think, and remember, we had to drain this in the third week. Or it's not like a completely matured form of the collection, but considering the sepsis and very stormy pancreatitis, the patient resolved very nicely after drainage, antibiotics with some symptomatic treatment from dermatologist. So that was a takeaway. High 29,000 amylase lipase, stormy pancreatitis, alcohol. Then we can really make sure that this can be a form of paniculitis, as it is a very rare phenomenon. Yes.
I think Dr. Sandeep Pal from online wants to say something. How to connect him to?
Dr. Pal, you're on.
Just a comment, because this patient, this pancreatitis usually occurs in pancreatitis, and because in this patient the lipase level was so high, so I think chronic pancreatitis may not be there. It was the acute pancreatitis, and at the same time, this condition is also very common in malignancy, underlying pancreatic malignancy. So we should very meticulously rule out pancreatic malignancy also. And the other thing in the treatment for the condition per se, like for the pericarditis, analgesics and all are there. But if it is like very much intense, some compression bandage might help. So that is another treatment which can be helpful in this pericarditis.
Yeah, this patient had acute pancreatitis only. We presented this as severe acute pancreatitis. He had fluid collection. He had a stormy course and fever. In fact, the clinical, because we wanted to emphasize more on the dermat aspects of it, that's why we didn't go into the details of the clinical history, but we tell you that it's a severe acute pancreatitis.
Shall we move on to the next case? Yeah.
I was just hoping to introduce the online chairpersons for a moment. So thank you, Sandeep and Muni, for joining in. Sorry. So we have Sandeep Pal here. Thanks, Sandeep, for joining in. Dr. Sandeep Pal is a fantastic gastroenterologist and advanced endoscopist in NH Hospital in Kolkata. Very experienced, does fantastic life courses, and we are really honored to have him here today. And along with them, we have our international chairperson, Thiru Vengadam Muniraj. Thiru is his short form. So Thiru and I are good friends from back in days when we were interviewing together for fellowship. Thiru is the Associate Professor of Medicine at Yale University in the US, and he's the Vice Chief of Endoscopy and the Director of Advanced Endoscopy at Yale. And he's the Associate Chief of Endoscopy there, as well as the Director of Bariatric Endoscopy. So welcome, Thiru. Thank you for logging and sparing your time. Thank you.
Thank you, Saurabh, and thank you. It's an honor to be part of your conference. Thank you again.
Yes. The second case is can a common GI medicine do harm? I mean, yeah, all medicines can do harm, and you have to be really a adverse drug reaction conscious physicians. We need a more safety physicians. And presenting the first case is Dr. Debashish Bala, and he will be presenting the first case.
Thank you, sir. Good evening, everyone. Uh, Today I will present a case. So,
Good evening, all. I'm Dr. Shubhankar Godbole. So, we start with the case. Yes, now we start with the case. So, we have a 15-year-old male with us who presented to us. His index presentation was in January 2022 at Old Midas. The weight was stable around 48 kgs, and the patient had a history of long-standing constipation since past 3 to 4 years. The patient had given a history of straining on and off, but there was no evident history of manual evacuation. No alarm features like weight loss, PR bleeding, lump in abdomen, or fever. So, as the good gastroenterologist, we always follow protocol. The patient did not have any alarm signs. So, we started him on diet, lifestyle changes. We did get some basic tests done. The CBC was normal, liver enzymes, creatinine was normal. Thyroid function test, which is a common entity to cause constipation, it was normal. Urine routine was normal, vitamin D was normal, and we also did a anti-TTG, that is testing for celiac disease, that was also negative. So just to get our doubts clear, we did a anorectal manometry for him, which came out to be normal. There was no evidence of dyssynergia. In the absence of alarm features, lifestyle changes were given and the patient was started on first line laxatives with polyethylene glycol and fiber along with some probiotic. He presented within 15 days along with his parents complaining of heartburn and constipation. Constipation was persistent. Medications did not help him. So we performed an upper GI endoscopy which showed antral gastritis. The RUT was positive. Also, the vitamin D was borderline low, so we started him on vitamin B12 correction and gave him H. pylori eradication therapy. That time, vonoprazan was not available, so standard PPI, amoxicillin, and clarithromycin was started. The patient was continued on laxatives. So this is the flow chart in January 2022. No alarm features. Feb 2022, within 15 days, he returned with antral gastritis, and then again he presented with at 2 months without any significant relief in constipation. So whenever a patient presents to us for the second time, whatever the age might be, we generally prefer to do either a cross-sectional imaging or colonoscopy. We did a colonoscopy to rule out any organic disease. Of course, it came out to be normal. We repeated his anorectal manometry just to confirm our doubt whether it is some some dyssynergic defecation. But even the second time, his anorectal manometry was normal. We confirmed H. pylori eradication, UBT, that is urease breath test was negative, and the patient was continued on laxatives. Since the patient did not show any significant relief, they sought a second opinion. The patient presented, the patient went to somewhere else, gave a history of sense of incomplete evacuation. He had abdominal discomfort on and off. CBC and TSH were checked again. Those were normal. The patient, of course, was continued on laxatives and he was started on mebeverine, which is a smooth muscle relaxant. Psychiatry referral was sought for low mood as per the history given by parents. The patient was started on fluoxetine, which they took for about a week or so and then discontinued. So from January 2022, 3 months apart, the patient was treatment defaulter and he did not show any significant relief in constipation. The patient was lost to follow-up for almost 1 year and then presented to some other center. Again, his CBC, LFT and CRP were done, which was normal. Barium enema was done in order to rule out Hirschsprung's disease. It came out to be normal. The patient was continued on laxatives and SOS suppositories. He again defaulted on the treatment and lost to follow-up. He went to a fourth hospital now, complaining of chronic constipation where he was admitted. The patient did not have PR bleed, no lump in abdomen. His routine evaluation was normal. CECT abdomen was done, which showed a doubtful narrowing at celiac artery origin. However, there was no post-stenotic dilatation. So it was considered as normal. Colonoscopy was done for the second time within 1 year. They found a normal mucosa till terminal ileum. Random biopsies did show some non-specific inflammation, but to no avail. The patient was continued on laxatives. He was started on prucalopride, which is a enterokinetic, and suppository was added on SOS basis. From January 2022 till August 2023, the patient did not have any significant relief in his constipation. And we came back to the square one. He presented to us in April 2024, that is a few months ago. We rechecked his routine lab evaluation. We again found it to be normal. Anti-TTG was rechecked, which was normal. Ultrasound abdomen was normal. So the patient was taking laxatives, he was taking enterokinetics. We referred him to our psychiatrist for some detailed evaluation as a matter of refractory constipation. I would like to invite Dr. Isha, who assessed him, to tell you what she found.
Good evening, all. I am Dr. Isha Alwalia, consultant psychiatrist at Midas Hospital. So, thank you, Dr. Shubhankar, for giving a detailed workup of this patient. Now, let's see why are we calling it unusual case of constipation. So when the patient presented to me, it was almost after 3 to 4 years of he being taking all sorts of treatment from multiple centers. So when I took his history, I got this is what I got. Patient had repeated intrusive thoughts of contamination and compulsive washing rituals, which started when he was 14 years of age. That which he reported self-remitted within next 6 months. However, now the symptom profile changed, and patient said that he after developed counting rituals. I would just like to explain what counting rituals are and magical thinking. So when the patient have some sort of intrusive, repetitive, or thoughts or feelings, they sometimes develop this set of symptoms wherein they count for us. It could be 11 times, 100 times, 99 times, or whatever number that comes to their mind. They have to do a certain counting in order to be relaxed in while doing any ritual. So they might think that if I don't count till 73, whatever, if I don't count it in my mind, or if I don't repeat this thought 73 times in my head, something bad is going to happen. So this is what, which is absurd, which is not going to, definitely it's not something that is into reality, but this is what a patient who has counting rituals does. So this child then continued to have this counting rituals and later developed preoccupation with incomplete bowel evacuation, which was at say 15 years of age. He reported tenesmus. He clearly reported that he spent 5 to 6 hours in the washroom, and there was history of persistent straining as well. He also reported from last say 6 months or so history of digital evacuation. So whatever he did not felt that he did not feel that he had passed the stools completely. It was so much so that he had to be removed out of the washroom forcefully by the parents. He would not just come out. And due to this, there was functional impairment in the form of he did not go to school, he did not do chores at home, he did not go to play out with friends, etc. He himself reported constant preoccupation and distress associated with these thoughts. And he said if he did not sit for certain hours, or he also had to count while sitting in the bathroom. He said if he did not do that, he would feel extremely anxious and he could not just make himself get out of the washroom. So that is why parents had to do it forcefully when he would not come out for hours together. On mental status examination, patient said that he felt low, he felt depressed, he was withdrawn, he was not being himself. He continuously, he talked about his mental obsessions, about counting rituals, and a persistent thought about not feeling complete evacuation, and compulsive act of sitting for a longer period of time till he feels that he has done it, or has to count some he said he has to count the number 99 for say multiple times, not exactly recalling how many times. He could understand that these are his own thoughts, but he could not understand why it were coming to them and why he was not able to avoid them. So insight was fair, wherein he could understand there was a problem, but he could not do anything about it. So with this set of history, apart from what Dr. Shubhankar had said, I diagnosed him as obsessive compulsive disorder mixed type, wherein there was equal number of obsessions and compulsions, both were present. Now, when do we call patients as OCD? that is obsessive compulsive disorder. So this is basically just the treatment that I had given, which was fluoxamine, which is a SSRI, selective serotonin reuptake inhibitor, which was optimized till 100 mg. Risperidone, which is a low dose antipsychotic, was given, and to reduce his anxiety, benzodiazepine group etizolam was prescribed. Now, when do we call a patient as OCD? So we have criterias which tells that obsession is something which is a recurrent and persisting thoughts, urges, or images that are experienced as intrusive, which he said it was intrusive, which was unwanted, which again he confirmed, and in most individual are marked by anxiety and distress, which again was present in our patient. The individuals attempt to ignore or suppress such thoughts or urges, or neutralize them, leads to further anxiety. So they perform these compulsions in order to get rid of the anxiety, but the anxiety does not still go away. And compulsions are again some compulsions are the behaviors, the act that they perform in order to get rid of it. So these behaviors, the individual feels driven to perform in response to an obsession, or aimed at preventing some dreaded event or situation, like I said. So this is what the diagnostic criteria of OCD tells us. Now, this form of OCD which we have seen here is not something which is very routinely seen. But it was not something that I was seeing for the first time. This is a rare presentation, but it does come along while seeing in OP. The common type of obsessions, just to brief, what are the common obsessions? Generally, we see our contamination, which this child had when he was 14 years of age, wherein he had multiple hand washing for a longer period of time, spent hand washing time more than 2 to 3 hours per day in hand washing rituals. Then others are harm related or compulsive checking. Then there are some aggressive obsessions, sexual obsessions. We are not going into details of this. So these are, or symmetry, some preoccupation with symmetry, that certain things have to be kept in a certain way, otherwise they feel anxious about it, and hoarding obsessions. So these are the commonest obsessions and compulsive phenomenology that we see in OCD. However, this was a little something which is rare, but it's not something which is not unseen of. When I went back to literature and read about it, apart from OCD, that's our part of the thing, I came across this bowel obsession syndrome from the gastroenterology perspective, wherein they have which is described in functional gastrointestinal disorder category. It does not follow the Rome criteria, but it is somewhere near, wherein it talks about overwhelming and irrational severe fear of fecal incontinence, ideational rambling over bowel habits, ranging from possible public humiliation to perceived unavailability of bathrooms outside the home, compulsive behaviors aimed at maintaining body control, including spending excessive amount of time in the toilet or restricting food intake, and various symptoms that overlap with number of disorders such as panic, social phobia, specific phobias, agoraphobias, without panic symptoms. So this again is something I came across few case reports wherein they talked about how these patients at some point of time who had IBS previously had had incontinence in public places, and that led to some features which were looking like OCD but were not truly OCD. But this kind of presentation which we are seeing has developed over the period of time, and what makes more of we could confirm it was OCD is varied presentation. The general other obsessive presentations were also there, as in contamination, as in counting, checking or counting rituals. So that makes more of we can substantiate the diagnosis here. Now, just telling how this OCD, how it like plays with our brain. So basically, OCD is because of the imbalance between the direct excitatory and indirect inhibitory CSTC loop. So what happens is that because of excessive thoughts that are generating, that our excitatory loop is involved in generation of those thoughts, and hypoactivity of indirect inhibitory loop, which is basically responsible for suppressing unwanted thoughts. So that's hypoactive, and this imbalance leads to something which is, say, responsible for pathophysiology of OCD. So this slide again tells us that in early phase, basically the emotional, if you could see here, huh, point, sir, am I able to point? Yeah, so this is basically DLPFC and ventrolateral prefrontal cortex, VLPFC and DLPFC. So this is basically required for cognitive and emotional processing in the brain of whatever thoughts that we get. And caudate is something that is, caudate nucleus is something which is associated with the motor behaviors. So when this whole circuit gets disrupted, we are not able to filter those unwanted thoughts, and they keep coming into our brain, and that in early phases cause anxiety, uncertainty, and increase in those behaviors which are not certainly required. And in the late phase, since it's the inhibitory loop, the indirect loop is hypoactive, we are not able to inhibit them, and compulsivity and habitual behaviors come into place. Now, talking about in brief about the role of neurotransmitters, since we are going to talk about the treatment. So serotonin, central serotonin depletion has a role in, that depletion is something somewhere causative in OCD. Glutamate hyperactivity in the CSTC loop, and striatal dopamine, which is associated with stereotypical or repeated behaviors. So that this forms the explains the pharmacological basis of the treatment that we give, and therefore it's important to know. I'm not going to detail of this. This is how the psychosocial development in theory of psychosocial sexual development, which we read. Just I would like to point here is this anal retentive, that is the anal phase of psychosexual development, wherein it is seen that if in children, uh, for whatever reasons, if they too much, if they are pressed upon perfection, and too much critical, if the parents, they are critical in terms of how they are doing and how it should be exactly done in the way that the adults do, the children learn that behavior, that perfectionism, and that somewhere, if they are not able to do when they grow up or when they become adults, it leads to some anxiety in them. So these can also lead to some OCPD, which is obsessive compulsive personality traits, and that can later on be say, it could be a risk factor in developing OCD. So this theory is not exactly temporally, we cannot tell that this is something that's going to, and in these patients this anal retentive nature of is generally seen. Now, what are the treatment options if now that we have an OCD patient? So first option is psychotherapy, which is exposure and response prevention. Generally, the evidence says that ERP, along with pharmacological agents such as SSRIs in the form of fluoxetine, floxamine. Fluoxetine he received, as you have seen in the case. SNRIs, venlafaxine, desvenlafaxine. TCAs, tricyclic antidepressants, clomipramine, which was the only drug that we used to give for OCD, and other novel agents. Some other newer techniques are neuromodulation techniques like ECT, repetitive transcranial magnetic stimulation, then direct current stimulation and deep brain stimulation. And in very severe OCDs, which are treatment refractory, anterior cingulotomy, capsulotomy, and limbic leukotomy has been done. So this is about how we treat OCD. So so what we needed to emphasize here is sometimes that a certain, this is I think my second case in, since I've joined Midas, which is almost now I'm nearing a year. I've seen two such cases wherein they had been coming over the years for constipation. They have visited multiple places, and eventually it turned out to be OCD. So this is something is a take home message, that if you are not able to, you have done all your workup and we are not able to come to a certain conclusion, it's always better to have a, a different view into it and just say you can refer or you can ask a friend if at all if it's required, but that's how we can help the patient. So summary is OCD, mind you, is a very disabling psychiatric condition, and almost 25% to 30% of the patient turn into treatment refractory patients. It's often routinely missed in routine clinical practice or misdiagnosed or mistreated, and is definitely associated with higher degree of comorbidity. Anxiety and mood symptoms are common, which was earlier treated for this case as well, and has a very complex neurobiology, is not as simple as I've given the chart to treat, because most of them do not say remit 100% as well. And there are multiple newer treatment promising options are coming up, which are are the future of OCD. So thank you. I hope you could take home the fact that if something is refractory, we need to like brainstorm and think like what's going on and if we can do something else about it. Thank you.
Thank you, Dr. Isha, Dr. Shubhankar. It was indeed a very interesting take on the case. Um, like you said, detailed evaluation is necessary because, uh, I mean, most centers don't have an access to a psychiatrist or they don't offer such comprehensive care. And then this patient could very easily be written off as a functional disorder patient or a psychosomatic patient, right? So if we don't evaluate the OCD angle adequately, it'll never be found. I would just like to mention something since you did speak about the anal retentive phase. Dr. Shobha Srinath from NIMHANS, who's an authority in child psychiatry. Once in conversation with her, we just asked her, what is the youngest patient of OCD you've seen? And she said she's seen a child, she diagnosed OCD in a 4-year-old child. The child had obsessions of contamination and the child refused to pass stool despite having the urge to because of the thoughts of contamination. So just a tidbit, even children as young as that can be affected by something like OCD, and that is indeed an angle that can be looked into. Thank you. Any questions from the audience?
So prognosis, since it's, I would say it's an early onset OCD. If it's a, this is what the history we have. If it's an early onset OCD, the prognosis is, there are multiple factors which will tell how is the prognosis, but early age of onset is not a good prognosis. Then a long term untreated, which is almost 4 or 5 years that this child has not been treated. So that again is a poor prognostic factor here. There, I think family understanding is still very poor since we have been trying to psychoeducate them about this not being an organic case, but they are still quite, they are trying alternative medicines and all. So these are few of the factors in this case, wherein multiple changing presentations, early age of onset, and untreated for a longer period of time are poor prognostic factors in this case.
Uh, so how's the follow-up of the patient with the treatment?
So that's what we have been. He has come once after index visit, but then they are still trying for alternative medicine. They are like not now. I think what last conversation I had with them was yesterday itself. So they are still not completely convinced that it's a mental disorder, and they said they would like to try a few alternative medicines and maybe then come back.
Yeah. Just a small comment that history of taking of the patient is very important to diagnose this. See, nobody in busy practice, nobody asks how many minutes you sit in the toilet. This person was sitting for 4 to 5 hours in the toilet. So that itself will clinch the diagnosis that it is something psychological. So I think that history taking is very important.
Next case. For the next case, the topic is colonic obstruction managed endoscopically. Novel application of endoscopic ultrasound will be presented by Dr. Saurabh Mukewar.
Okay, good evening, all of you. I think this is going to be a brief case. Just a short case here. This is a 68-year-old gentleman with history of diabetes, came with crampy abdominal pain since 2 months on and off, had postprandial pain associated with some fullness, constipation, with weight loss of 16 kilograms. So he came to Midas with a history of melena, increased intensity of abdominal pain with postprandial vomiting. On examination, he was cachectic, malnourished, had dry mouth, he was dehydrated, hypotensive. MAP was MAP was 50. Ejection fraction was low, it's only 20%. So initially on lab evaluation, his presentation revealed severe hyponatremia as he was dehydrated, mild rise in creatinine, and uremia with BUN of 142. So he was in the ICU. He was on vasopressors. Slowly, his sodium improved, and at that time, when the creatinine got better, okay, we decided to proceed with a CT scan. And this was the finding on the CT scan where the entire small bowel was diffusely dilated. And overall, based on the radiologist's impression, the obstruction was felt to be in the right side, suspected in the right colon. So in this scenario where this patient has a colonic or say right-sided small bowel obstruction, but this patient is cachectic, malnourished, and was really, sorry, excuse me. This is, let me open this again. So this patient was cachectic, malnourished, and I'll just pause it for a moment. Yeah. So we had very low ejection fraction, so surgically was considered, but of course a very high risk given his clinical scenario. And therefore we said, okay, what can we consider in this case? So starting with the regular colonoscopy, as we advance the scope, the dilated bowel loop was seen in the colon as well. You can see large amount of stool, so this was really hard to prepare. And I'm just going to pause for a moment. So this is what we found, which was in the right colon, the mass which was obstructing. So in this scenario, a standard attempt at placing a stent across into the small bowel was not feasible given the size of the mass, and we could not absolutely get access to the small bowel to do a colonic stent. And surgery was very high risk. So we decided to consider something unique in this case, and I'll explain. So this was the mass. We took biopsies, which later turned out to be malignant. So what we decided was to perform an endoscopic ultrasound guided decompression of the obstruction. So before I start the case, EUS scope, when we go across the anus, we generally don't go more than 20 centimeters. So you're by and large limited to the left side of the colon. You don't reach the right side of the colon. But in this scenario that we had to do something on the right side, we wanted to go as proximal as possible. So what we did was we placed an over tube, which is a flexible tube that allows us to go and negotiates the turn in the left side of the colon. And slowly the scope is advanced across the over tube, and we managed to get into the right colon. And this is what we could see on the screen. You can see that whole distended, filled small bowel when visualized. And a lot of you don't do EUS, but this thing here, this is all ascites. So this patient had ascites and a distended small bowel. So we managed to, now the question was, are we really in the right colon? Because ideally you don't want to do very distally. So I had Kiran, who was my fellow, and he's just left. But I asked him to keep the hand on the right lower quadrant. So here's Kiran putting his hand on the right lower quadrant. And what we said is, okay, let's see. So with my EUS scope was right next to where his ring was, suggesting that we had successfully reached the right colon near the cecum. And then we decided to proceed with, again, confirming that we are in the right location. So with an appropriate window, this is about 3 centimeters in depth, we put a 19 gauge needle. We put some contrast, and under fluoroscopy confirmed that we are in the right location in the small bowel. And following this, we went ahead. Oh, shit. Okay. So let's see here. Yeah. So we go in, we placed, distended the right colon, sorry, the small bowel here. And then we proceeded with placement of a cautery enhanced metal stent. Axios and all of the gastroenterologists are probably very familiar with this. So this is a 20 millimeter diameter stent, and we are placing this from the right colon across into the small bowel. And you can see there's a gush of small bowel obstructed contents, greenish contents that could be seen. And this we confirm that the position of the stent is correct. So following this, as you can see, this is the X-ray prior to the procedure, and post-procedure, following the coloileal anastomosis that's been performed, there's decompression and the air fluid levels are gone. So proud to say we are the first in India to do such a case. The patient had past flatus, the vomiting resolved, and unfortunately he went against medical advice on day 2 for us to see. So this is not a very commonly done thing, and this is one series out of Japan, which is 26 patients in multiple centers where they did something similar for colonic obstruction. The defined technical success is successful deployment of the metal stent between colon and the dilated small bowel loop, and clinical success as resolution of the bowel obstruction symptoms with passage of bowel movements and can remove the nasogastric tube. So this is essentially the data. If you see in this series, they're elderly patients with 96% having a malignant obstruction, and almost 60% had ascites. And some of those had prior surgeries, with including colonic resection. And in terms of the symptoms, majority, as you would expect, had abdominal distension. A lot of them had chronic obstruction, almost more than 4 weeks old. And procedurally, if you see, they found obstruction in the small bowel in almost 77% cases. And the type of deployment was colocolonic in 77% and enterocolonic, well, coloileal rather, it should not be colonic, because they went from the colon side to the small bowel or small bowel to the colon, which was in 23%. And majority of them, they deployed the stent in sigmoid colon, and a freehand technique like what we did was the majority of the patients. Now, question really for us was whether this patient will develop diarrhea, because we have really bypassed a large segment of the small bowel or colon potentially. And if you look at this series, 2 out of 26 patients developed diarrhea. So that was our overriding issue, that we are doing a major bypass. So hopefully the patient doesn't have diarrhea. And only 2 in this series developed, and 1 responding to medications, and only 1 had persistent diarrhea. And the locations was not even the sigmoid colon, it was in descending and transverse colon in these patients. And in all the patients in which they even did across the sigmoid colon, if somebody has to, they didn't have post-procedure diarrhea. So I'll end my presentation here, and I'm happy to take any questions. So thank you.
Saurabh, can I ask you a question? Can you hear me?
Online chairpersons want to ask some questions.
Yeah, hi, Thiru. I think you're an expert endosonographer.
Yeah, Saurabh, that's a great presentation. I missed first couple of minutes of the presentation. That's
Yeah.
very impressive that you're able to get the EUS scope that far, let alone even upper scope or a colonoscope on a patient who have a hard time having a bowel prep. How far was it from the anus?
Well, I think it was in the right colon. So I mean, I suppose after we shortened the scope, we were at about 70 centimeters. So in the
It's
right colon,
amazing.
yeah.
Yeah, the
So we got
linear
lucky that we could manage to get there, because it was a bit of a task. As you can see, unprepped colon, distended, patient sick, anesthesia doesn't want me to take much time, obviously. So yeah, we could fortunately get there and get it done soon.
No, that's very impressive because the linear EUS scope, as we all know, it's so stiff and so hard to get through beyond sigmoid colon, even with guide wire or over tube. I think only very talented endoscopists like yourself can get there. So can I ask what size lamps did you use, Axios did you use?
So we used a 20 millimeter lamps. I think we didn't want it to obstruct, and we had a good runway. So we had a 3.5 centimeter runway in the small bowel. So therefore, we could use a larger size lambs and deploy successfully. Had we had a smaller runway and there's less space in the small bowel, then we would have chosen something smaller. But I think larger is better. Obviously, you don't want that to have another obstruction later. So, yeah.
Yeah, that's great. 20 will be very good because patency will be awesome. And I saw some ascites next to that small bowel loop.
Yeah.
Do you get concerned about any leak? Obviously, this is a covered stent.
Yeah, so I think we've been able to push our boundaries a little bit because we've historically had ascites has been a contraindication for such procedures. Uh, but I think we've done a fair number of internal anastomosis, almost about 100 patients at least by now, in different various forms with pancreas and bile duct and small bowel, etc. And I think in the amongst our 100 plus series, about 25 to 30% have been in the setting of ascites. So I think we have grown comfort in this. Of course, there's a high risk of complications if you don't do it correctly. But I guess if you do it swiftly, you can manage to do it properly. So in fact, we are coming out of the paper in biliary drainage with ascites and not, where we see very similar complication profile. So I think it can be done. That's my belief. And there are some other reports now which have shown that. But yes, I wouldn't recommend anyone starting out to do it in presence of ascites. You probably want to wait and do at least 30 odd cases before you venture out into the more advanced ones. Yeah.
It's a really masterful demonstration. I
Thank you.
missed, did you use guide wire while passing this axia stent, or was it
No,
a
we didn't use guide wire. We just injected, I think we just wanted to be sure what we are looking at is not some random loop of the colon because the colon was very distended. So, I mean, although 99% in my head, I knew what I'm doing is right, but I just wanted to put a needle, put some contrast, just like show that, yes, it's a small bowel, and then put a axios after that, basically.
Yeah, and also your fellow's ring was confirming that is the right
Yeah.
lower quarter.
So yeah, that was the other issue that we didn't
Yeah.
want to make sure, we didn't want a shortcut because you don't know where you're putting the stent, right? You could be potentially in the proximal jejunum or something. So then obviously, ideally not, but if the in colonic obstruction, there's no way to tell where your stent is being placed. We presume in the right colon, you presume it's the ileum, hopefully. But yes, if you're on the left colon, if you're on transverse colon, then you don't know. You could potentially be going in the jejunum. That's the reason we really wanted to make sure in the right colon. Yeah.
Now, as you mentioned, even if this patient has loose stools or diarrhea, I think this is the best outcome this patient could have expected.
Yeah.
Looks like it's not a surgical candidate, and
No,
even
he was very
colonic
ill. He was a
plans.
NORAD and EF of 20%, cachectic,
Right.
hypoalbuminemic. So certainly that was not an option at all for this one. Yeah.
That's an excellent case, Saurabh. Congrats.
Thank you. Thank you. Any questions? Yeah.
That was a very impressive presentation of such a difficult case scenario. Putting a stent, what Thiru sir had told, by taking the US scope to the right side and putting into the loop nearby to the right side of the colon. That's very impressive. By
Thank you.
putting in the distal ileum, most probably you put in the distal ileum.
Somewhere in the ileum, I think.
Okay.
We would
So the diarrhea question arising out of the short bowel will be taken care of. I think so.
Yeah, no, so the diarrhea was not a problem
Not a
in our
problem.
case. And that was the impressive part in the series also. A lot of patients did not actually have diarrhea, despite what we would expect. So that's a reassuring fact, Yeah. Okay. Good. Thank you. Thank you so much. Yeah.
So inviting any questions, sir?
Yes, good evening, all the chairperson, good evening, all the audience out here. So we are very fast on this since we are waiting from long. Let me start with this is a young male who had a history backdated in 2010. He was just 17, 18 years of an age. He was diagnosed to have an EHPUO secondary to an upper GI bleed, for which the endoscopic varicose banding was performed for that particular year in multiple times. And since then was put on also beta blocker. But again in 2017, the patient again had a very massive GI bleed. He was residing in the nearby town only with not great facility, but somehow reached in the center nearby where they found to have a splenic artery aneurysm. At the same time, since the patient has a repeated episode of an upper GI bleeding, the patient was also considered for any portosystemic shunt, which was being evaluated by CT scan, was failed because of poor visualization of the splenic vein. So during in that center outside, the patient, since there is no patent vessel or patent shunt was there, patient underwent a splenectomy with devascularization in 2019. So he was doing very well. Post surgery, he was doing well. The bleeding, the varices, decompress, all doing very well. But in November 2022, he came to Midas with an history of an obstructive jaundice. And in the evaluation of obstructive jaundice, we found that patient having some mid to lower CBD stricture, which is pertaining to an probability a cause of an extrinsic compression because of an portal biliopathy. So with limited information on that particular thing, we did an ERCP and we put a fully covered sense for that stricture along with an double picture, along with a small plastic stent to anchor it. But patient post stenting started to throwing a fever, which is really not explanatory because the patient not having any IHBRD, no cholangitic abscess. But subsequently, within a span of 1 month, because of persistent fever, and patient was also a doctor, by the way, he's also considering, son, this is not working well. I'm having a fever, so we had to remove the stent within a 1 year. So in that removal of an after ERCP, there is a partial resolution of stricture, and all the stents were completely removed. Till then, the patient was doing fantastic. 1.5 years, no issue. Beta blockers. He was taking an ursodeoxycholic acid, doing very well. Now he presented after 1.5 year with a fever and jaundice, which simulating a picture of a mild cholangitis. On evaluation, found to have an elevated WBC, raised bilirubin in the tune of 3.2 with raised alkaline phosphatase, normal INR, ultrasound suggestive of same portal cavernoma, with now distinct vision having developing a more severe, more symptomatic form of an biliopathy in the form of IHBRD. And now even the fibroscan what we did showing some changes of an fibrosis in the patient. We're doing a F3 fibrosis. So with this mild cholangitis, we initially conservative management, persistent fever was doing. So just to explain, I just not going into a detail because of a time constraint. So a long period from 2010 from EHPO diagnosis to 2022, 12 years was required for this patient to develop in the form of biliopathy, just for that timeline. So we did an MRCP on that particular spleen. What is there to MRCP suggests, as you can see, there is an IHBRD which is very disproportionate, which is more seen on the left side as compared to right side. There is an suspected extrinsic indentation seen over the CBD, which is not very nicely visualized in this given image, and the gallbladder was over distended. So with this information, so we went for a ERCP this time. So I did an ERCP. We can see a previous site of biliary sphincterotomy. I cannulate the bile duct, and with a limited time, since the patient was having cholangitis, I leave a very limited contrast to delineate what exactly going into the common bile duct. And while this cannulation, I do large amount of flush considering the patient has cholangitis. I can see some stones coming out of the papilla, very sludge material also coming out of the papilla. But what I can realize, as you can see, after doing flushing and able to get into a cannulation into intrahepatic biliradical, it started oozing in front of my eyes. So before doing any treatment of some extraction or some getting evaluation of common bile duct, it was starting oozing. Though we had taken care by giving a terlipressin infusion during the procedure, but I had to very immediately console at stop, the bleeding stopped during partly stop. I put a nasobiliary drainage, came out, the patient was in cholangitis, and just put a nasobiliary drain and came out. And watchful the patient was improving with this treatment or not. So post ERCP, patient was continued on terlipressin bleed, patient relatively stable, don't bleed, hemoglobin was stable. We did a portovenogram for this patient to see what is there. But in city also, there was a post splenectomy status. There is no hardly any veins appreciable. There is distended gallbladder was seen. So not very great information what we get on CT. So whether there is a shuntable veins, that's just a thing. There is a stent can be seen. The NBD was seen on the right side. So with that information, so with that thing, after settling the cholangitis, the patient was all this thing. We thought that what should be a plan of management. Now at the end of the day, I don't have an exact cholangiogram what we are dealing, a stricture, a stone, but we thought that okay, let take like ERCP with that proper precaution of terlipressin drip. Let the relative consult regarding may require a fully covered SEMS also if the patient bleed during the procedure. So we thought that yes, why not to do an again cholangioscopy. So first of all, to doing cholangioscopy, I really want to get into what exactly the collaterals are there. And now from our institute, we're really doing an endoscopic ultrasound to get into what are the collaterals are there, whether there is a pericholedochal varices or there is an intracholedochal varices, or where is the exact location of varices, so that we can plan definitive treatment for this patient. So we can found, as you can see on the side, is a radial scope which just passed into that on the first part of duodenum, and we can see a CBD which is measuring around more on 5.9. There is some filling defect which was also seen, and during this evaluation we can see a very much there is a picking of this all the color Doppler around the gallbladder and along the common bile duct. We can see if you can able to appreciate, and there is a last there is a collateral seen from here. I just get it fast forward for you people. Yeah, yeah, yeah. So you can see, yes, some droplets becomes are going into the, so we really think it's a pericholedochal varices. Suspected intracholedochal varices was also made forward. So with that information on the endoscopic ultrasound of dilated CBD, filling defect in the CBD, and some intracholedochal varices versus pericholedochal varices, we given information that we need to go by cholangioscopy, see what's going inside the common bile duct, and decide our line of treatment. So with that information in the US, we did a cholangioscopy, we did a cholangiogram. Now this time a cholangiogram, we can see a stones with angulation, indentation in the proximal CBD. And now I can definitely can't do it inside just like a balloon traction, I can say, because since the patient just had a bleed right now a couple of days back. So I pass my cholangioscope inside the common bile duct, and what I can see in common bile duct, definitely there are some indentation, extrinsic compression, which may be because of an pericholedochal varices out there. So I can reach to that I cross that hurdle of little bit into a distal CBD, and the proximal CBD I can see a stone. So with that information, while passing the scope, there is extensive compression, periodical varices. It was really not for feasible to do any normal. So we decided on that table and also called the relatives that yes, we can do a laser lithotripsy, complete the fragment the stone, not use any balloon extraction, not using any sort of further sphincterotomy, and really blast it in that in a manner so that it can get completely fragmented. So I can see now that the stones are completely getting fragmented. Usually when during the procedure, if the stones get dancing around us, we can that we have achieved. But since this was a very difficult, we can't do a balloon sweep. It's our responsibility just to completely fragment in a very smaller piece and put an stent, not do any further line of treatment. So after that, there is a complete clearance of duct was achieved. Post procedure, the patient remains completely asymptomatic, no complication, fever really reside, and really he is on the follow up. We can call the stent. We can remove the stent in future in a couple of months and see whether anything residual things or not other. So yes, cholangioscopy and endoscopic ultrasound has helped me to decide that we should not go blindly just by doing a just balloon sweep, so that the bleeding event or hemophilia can avoid it. So I just come to a fast case of another case which is of similar profile but not exactly HPVO. She is a 60-year-old female with a known hypertensive. She was diagnosed as a chronic liver disease with significant portal hypertension in 2023, where on endoscopy during evaluation found to have an large esophageal varices. She was advised for endoscopic variceal blinding outside, but patient was preferred to go on beta blocker considering there is no RCS. So patient remained asymptomatic for that on beta blocker with no other further decompensation. But in August 2024, she started to throw having an jaundice, itching, fatigability, anorexia, weight loss, and outside found to have an patient has started developing a more about an obstructive jaundice, which is more secondary to the CBD stone with suspected biliopathy. This was reported in outside CT scan. So MRCP is also done. We don't have a flames. The patient came with an MRCP report. They can see there is an abnormal signal intensity noted in the common proximal bile duct with an hepatic confluence query neoplastic etiology. Oblique calculus in the mid CBD with moderate IHBRD, and there is definitely a chronic liver disease with portal vein thrombosis and cholelithiasis. So this was a very report going here and there, but we come to know that definitely a chronic liver disease, portal, there is a common bile duct stones which is really having the disturbing the patient and increasing a jaundice. So outside hospital, they did an endoscopic ultrasound. So they reported it is having an CBD stone with pericholedochal varices and definitely a portal vein thrombosis. So again, on the same profile, the endoscopic ultrasound is giving the information that patient is harboring stone at the background of pericholedochal varices. So ERCP was attempted outside, And ERCP suggests you there is a stone which cannot be retrieved, and they found that they did a biliary sphincterotomy. They also slightly attempted a biliary sweep, but they were limited because the stones were not coming because of a larger diameter of a CBD stone. So with this the patient stented, jaundice improved on that particular time, but again she presented with a Midas within a 1 month within increasing jaundice, maybe because of stent dysfunction. So by the time she came in last one, we found the bilirubin has rose to 13.8, usually not seen in the setting of an very stone disease or portal biliopathy, but definitely she was having some and liver decompression also at the same time. So with a persistent jaundice, patient came to us. We did a CT scan just to make sure any collaterals. We can see it gets very fast. There is a bilateral IHBRD which is seen more on the left than right. The stent can be seen in situ. There is a portal cavernoma formation which is reported by the radiologist, and there is a portosystemic shunt from splenic hilum perigastric which is draining into left renal vein. So basically, she is a case of chronic liver disease with chronic portal vein thrombosis with portal cavernoma with development of all the collateral which was found, which is very distinct from the prior case of which is having an EHPVO. So in summary, this patient having a chronic liver disease, cryptogenic with child B and male 22 because of raised bilirubin, the child and male score were really on the higher card. Patient was having a large esophageal varices which is non-bleeding and had now this time presented an obstructive jaundice with periducal varices, and there is an incomplete CBD stone clearance as per reported in the previous ERCP. So as usual, the same options were as in the previous case. We had to do a limited option. The patient having a perichoroidal varices. Relatives were counseled regarding a development of an bleeding during the procedure, requirement of fully covered SEMS as usual. A terlipressin infusion was also given at the same time. And this time, as you can see, the previous site of biliary sphincterotomy can be seen. And again, the CBD was cannulated. And now the cholangiogram also obtained suggestive of a filling defect in the, you can see in the there is a stricture or some extra narrowing in the mid CBD and proximal CBD. There was a stone, and the cholangioscope again was advanced. And on cholangioscope, this time was a very nicely, we can see a column of an esophageal, more a column of an very varices out there, which is really oozing in front of my eyes. And at the end of it, and we can see a stone also above that column of an varix. So it was very first time in my eyes I can see a intracolloidal type of varices which is seen on cholangioscopy. So I can see a lot of sludge material out there. There is a lot of vascularization seen in the common bile duct. And then you can see, yeah, on 12 o'clock and 11 o'clock position, you can see a varix here. There's a very large indent, just like a indentation, what you call, or something is there. So it was really oozing in front of my eyes. Slowly the blood was oozing. So I can able to across my cholangioscope beyond this extrinsic or more about intrinsic to my eyes. That time I can see the stone was not large as enough to cause, but it was because of an extrinsic indentation or some narrowing in the distal end that is making the stone making difficult. So same like on previous case, I started using a laser lithotripsy. This time not only blast the, I can able to fragment in a powdery form so that it can help, because I don't have a limited option. I can't pull back the fragmented stone by using a normal techniques of a basket or a balloon sweep. So it was a, so we started blasting. You can see the now it's really fragmented to a very smaller forms. Even the dancings, the stones we used to target in a very appropriate manner so that it not cause injury to the mucosa. So you can see on the left hand side on the endoscopic images, we can see a large stone fragment coming out from it. So without using any normia basket, without using any type of balloon sweep, we just start blasting. Little bit take a longer time as compared to previous, but I think we can contemplate this procedure around 20 minutes and achieve the complete CBD clearance. And for safer side, after complete fragmentation, I also put a nasobiliary drainage and also put a stent, so that for a couple of days I start flushing out the nasobiliary drainage. All the stones should come out from that CBD, and that is all. That is how I can see. And now on withdrawal, you can see a complete CBD has been clear in front of my eyes, without any complication, no hemophilia, no bleeding. Yes, yes, far forward. Sorry, yeah. Can see a complete clearance, yes. And I can do a final cholangiogram for you. Yes, I can put an NBD and nasobilirated, both has been put for better things. In this can see an NBD on the left hand side and a stent on the right hand side. We can continue flush the thing. And post procedure, no completion. We can continue NBD lavage continued for a couple of days. Thereafter, we removed that NBD lavage. Patient bilirubin started to reduce in front of our eyes. So in 3 to 4 days, patient was really improving without any further complication. So let me have a little 5 to 10 minutes regarding a portal cavernoma cholangiopathy. So let me see that portal cavernoma cholangiopathy is mainly reported in the patient of EHPVO in a tune of frequency of 80 to 100% in EHPVO, but is not in EHPVO. It can also be seen in cirrhosis of liver in the tune of 0 to 33%, and also in NCPF is tuned into 9 to 40%. As you all know that majority patients are asymptomatic and only small percent of patient present with symptoms. Coming to very important is a natural history of an portal cavernoma cholangiopathy. There are many theories which are say it is an EHPV or portal cavernoma cholangiopathy is a non-progressive disease. But in all the literature, it has been seen from an onset to an development of cholangiopathy, there is a lead period of 8 to 14 years in various studies. So basically it has two stages, symptomatic, asymptomatic. In symptomatic, patient has a classical abnormalities, often laboratory abnormalities, ductal abnormalities, and also have the patient has symptoms for that depending on jaundice, cholangitis, and further same thing. Asymptomatic, just patient have some incidentally detected abnormal caliber of an duct which can be seen on MRCP or CT whenever you did. But there is also another stage which is called as a complicated. This patient was really a complicated cholangiopathy. The patient having an choledochal varices, strictures, stones. So all forms of severe form was also developed in this patient. And the lag period was also in the first case around 8 to 14 years. Though this is a cirrhosis patient had developed very early development of an of cholangiopathy. This is the same thing what I called classifying collaterals for for all gastroenterologists and endoscopies is very important. Where are the collaterals, and that will decide what treatment should be offered. Just blindly sweeping the biliary gland many often has burnt our hand that patient we need and bleeding, we need to fully cover SEMS and we have to salvage our patient. So now in our hospital, we really do an endoscopic ultrasound for delineating what is the type of the collaterals the patient is having and decide whether we can do a blindly balloon sweep, biliary sphincterotomy, or the patient will require a cholangioscopic and laser for the upfront for this patient, because it has a good differentiately into a paraesophageal EP into intracholedochal varices and subepithelial varices, and sometimes it is detects a malignancy which can masquerading as a portal cavernous cholangiopathy. Everyone can is known for that. So in coming to a management, as I all know, asymptomatic no endoscopic treatment is required, and for management of a symptomatic patient we need a two thing. We have to reduce the portal hypertension, at the same time relieve the biliary obstruction secondary to water biliopathy. So usually treatment is given in the phase manner. In first manner, we do a biliary clearance and managing of strictures. Just like the patient present in cholangitis, some stone, decompress by doing some endoscopic treatment. Second phase, look for a patent vessel, patent shunt. If the patient is a shuntable vein, shuntable vein is there, definitely encourage our patient to go for surgery. Most common surgery is PRSS, what all our surgeons do. And third, sometimes the patient may develop, is not like a definitive, some patient develop a stent occlusion, and sometimes we have to, this patient may have a lifetime, some endoscopy, some other form we have to do it. Non-candidates of surgery, just our first patient was not, shuntable vein was not done, so they done just a surgical splenectomy and devascularization. And yes, definitely liver transplantation is reserved for the patient having a secondary biliary cirrhosis, recurrent cholangitis, unsuccessful control of portal hypertension in spite of the shunt. This is a very important, very can looks a very complex form, but I can see if a patient having a symptomatic form of cholangiopathy, if the patient having a stone stricture, we can do an endoscopy stenting with a due precaution of a development of an hemobilia. This patient required multiple interventions in their life. They are not like a single intervention will save the patient. But if the patient is having a good shunt, go for the shunt surgery. That is definitely going to in long term for the patient. And the patient who are non-candidate for shunt or patient develops some secondary biliary cirrhosis, liver transplantation becomes the most important. But during this today's presentation, I really want to emphasize on this single operator cholangioscopy. I reviewed entire literature in portal biliopathy endotherapy. There are hardly any notes about the cholangioscopy laser. I can only found a one paper from Ramchandani et al., where he just do a case series of 5 patients, where he really emphasize on pancreatic on endotherapy of biliary based on the presence of an varices. So as you can see, if the patient has a symptomatic cholangiopathy, if the patient having a get a portovenogram, if it is a shuntable, go for a PRSS type of surgery. But if the patient is not at the time of PRS is not feasible, you can directly go for peroperatal cholangioscopy. Make sure that patient having an intracholedochal varices or not. You can see if the patient having an intracholedochal varices, avoid balloon sweep, avoid stricture dilatation. That will definitely lead to a hemophilia. In this patient, we both of the patient having some sort of paracholedochal varices or intracholedochal varices, we opted for cholangioscopy, laser lithotripsy, a more safer option without any major complication. Same happen with an extensive compression. Yes, interrectal ultrasound is also a modality that can give information, but with the help of cholangioscopy and also endoscopic ultrasound, we can really make sure that what type of varices we are dealing. So this was a very important tool. Now time we should really start using endoscopic ultrasound and cholangioscopy in a patient with having a symptomatic portal biliopathy. So in take home message, this cholangiopathy is commonly seen with EHPO rather than cirrhosis and NCPF. Symptomatics are seen in minority of the patient. Majority needs multiple treatment during the lifetime. As you can see, on a single interventions will not help. Many of you have been known. Combined approach is required. We know endoscopy and surgery should go in hand. Patient should be rightly referred to the surgeon if the patient having a shuntable vein, and patient accordingly has to prognosticate. Cholangioscopy and endoscopic ultrasound can be used for deciding the endoscopic treatment option, and sometimes also very important to what is the etiology of an obstruction. Thank you. Thank you.
Thank you, Bhushan. That was, I think, a very clear example of good application of technology, a good clear thought process. These are very difficult patients to deal with.
Absolutely, sir.
They bleed, they are septic, and then you don't really often have a window where you can do any kind of surgical work between the episodes of cholangitis. So one often unused surgical approach for patients who are unshuntable, who have biliopathy, which you are unable to tackle, is to do what we were doing earlier for uh, uh, tumors of the hilum, that is a segment 3 bypass. There are no collaterals, it's easy to do, and then you can tackle the rest once the biliary decompression has taken place. But very nice.
Thanks. Thank you.
Yeah, I think
Uh, very good cases. In cases where there is a single dominant stricture in the CBD, and if there is a shuntable vein, or even though you have a very large choledochal varices or intercholedochal varices, it is advisable to go for shunt surgery, and then if you have any stricture dilation or a
Absolutely,
stone
sir.
removal, you can go for that.
Absolutely.
If there is another type of like type 2, 3, or 2, 3A, 3B, or both type of this cholangiopathy, and the patient is can be managed like in this way. And but in the cases with the type 3, if the patient is developing cirrhosis, then definitely the only choice remains is a liver transplantation.
Yes, sir. Yes, sir. That can be the answer.
so. I think thanks, Bhushan, for nice presentation. So I think the two issues which we felt were novel in this case was one is cholangioscopy and lithotripsy is by and large in a setting of intraductal varices. So if you look at the video of the next case, it's like an esophagus with red whale signs and a big intraductal varix. We are not used to these images because we don't do cholangioscopy standard EHPVO. It felt like you're doing an endoscopy of the esophagus with a large varix and a red whale sign that can burst anytime. So you have to be extremely cautious when doing laser lithotripsy in these settings. And that's why when we look through, we realize that nobody really does it. And I think people don't do it. The reason is that there is a risk of bleeding. When you do laser, inadvertently, you could hit the choledochal varix and then the patient would bleed. So that is one thing that we could identify in these two cases when we did it successfully, that the patient did not bleed due to the cholangioscopy lithotripsy. That's one. And the second thing is, when we do laser lithotripsy in cholangioscopy, we don't always break it to the point that everything comes out. We still follow it up with balloon and basket sweeps. Now, the problem in these cases is that they have such big varices that I said, okay, fine, I'll do cholangioscopy, but what about the remainder when I have to pull out those fragments? I'm still going to cause friction. So then what learning we came from these two cases is that you don't stop at a standard laser lithotripsy how much you do. You keep going until you make it so small that it automatically comes out, which is something more beyond that we standard otherwise do. And then we put nasobiliary drains, we flush it, and ultimately both cases, without even using balloon or basket once, the entire duct was cleared. So I think these are more technical aspects of ERCP cholangiscopy, but nevertheless very relevant because one, we could overgrow our fear of doing laser in this setting, and two, we could identify an alternate solution to basket and balloon. To the point that I told Bhushan that I think moving forward, all cholangioscopy, all cases with EHPVO with active varices, no shuntable vein, first, do not even bother with anything. Go with a cholangioscope, break the stone down, treat it, and come back. You'll do two things. You'll find whether it's a stricture from inflammation, from fibrosis, or it's an intrarectal varices. Very hard to find. Otherwise, you can do that. You can treat it. You can take care of it, and it can be done very safely. As opposed to attempt one, attempt two, the patient bleeds, turly press, and everybody's heart rate goes up, goes in the ICU. It's just a mess. So this felt so clean and so nice after having all these bleeding complications in the past that I thought it was a very novel approach. And I think we'll write this up, and I'm sure there'll be more reports of that coming. Yeah.
Yeah, in fact, doing an ERCP in a patient with portal biliopathy is always a nightmare. First patient which I did, only I was not knowing that this will bleed so heavily. So I dilated the patient and there was a gush of blood. An injection terlipressin had to be given. We were not prepared. We had to put a self-expanding metal stent to stop the bleeding as a rescue procedure. So, because there are so many gastroenterologists, I would like to give 2 or 3 messages. Number one, whenever we take a patient, you have to counsel them, have a video recording saying that this is a very dangerous situation, that the patient can bleed anytime. You should never dilate the patient's stricture with balloon. Subsequently, I realized that when even in spite of pulling the balloon to clear the duct had led to massive bleeding. So, I mean, so one thing is consoling the patient properly. Number two is injection terlipressin has to be given earlier prior to reduce the portal hypertension. Thirdly, you should be asking the patient to pay for self-expanding metal stent in as a rescue procedure. Unless until that, you should not be doing the procedure. Thirdly, now we have seen that the approach has to be different. Like you don't do ERCP, you do ERCP, but don't remove these stones unless you examine with cholangioscope. So the approach which we're doing that, let's remove these stones, but that's a wrong approach. I think probably it would be safer approach to do an cholangioscopy, inspect inside, and then probably remove the stone. Fourth is those who are very unfortunate that they don't have a shuntable veins, and those are the ones which are very difficult to tackle. Now, the first patient, a doctor having CBD stricture, I was asking Saurabh that you should be injecting the pericolloidal varices to reduce the pressure and the obstruction, because otherwise he might land up in secondary biliary cirrhosis. We don't know now. He's good at present, but he has already F3 fibrosis. So that is a big question, because doing intervention with US of obliterating periducal varices, sometimes even after surgery, the patients have fibrotic stricture. It's very difficult to know whether it is because of compression or ischemia causing permanent stricture. So these patients have to be concealed to a great extent that in spite of removing varices, removing shunt, you may have a permanent stricture which can lead to secondary biliary cirrhosis, and transplant may be the only option. We have seen patients who have been operated for gallbladder without realizing that the patient has EHPBO, and patient had massive bleed and rushed to higher centers. So these are all the examples. So portal biliopathy is not very common in Western countries. We have more of EHPBO, so we see many of these patients, and these are very difficult to tackle. The message is, if you have jaundice in a patient with portal vein thrombosis, always suspect that the patient has portal biliopathy and be careful. Thank you.
Even if there is a isolated, very high persistent alkaline phosphatase for more than persistent 8 to 10 weeks, you can suspect there can be some stricture or stone in the CBD, secondary to portal biliopathy.
Right, sir.
Any questions from the online chairpersons? There one. Okay, there are no any comments or any questions in the chat box. The last case is not going. We are is cancelled because of lack of time, and I would like to present the vote of thanks.
Yeah, sir. So yes, we'll present this bird care is kind of somewhere in some other meeting or in next meeting. It was an interesting case. I really really thanks our sponsors Abbott, and also our chairpersons, Dr. Prakash Sonkusre sir, Dr. Snell sir, Dr. Vijendra Kirnage sir, Prakash Jain sir, Dr. Neha Babe just left, and Dr. Ivan Sushil Pandey for chairing such sessions. I also thank for the online chairperson, Dr. Muniraj and Dr. Sandeep Pal, for really giving their valuable comments. I now really welcome all of you. I'll not be waiting for anyone for cocktails and dinners. Thank you very much. Yeah.